The first group of drugs we're going to look at are the CNS depressants. We're going to focus on alcohol, barbiturates, benzos, and narcotics. So the first drug class we're going to talk about in terms of abuse is ethanol. Not that any of you have any familiarity with this drug, but specifically this is a NMD antagonist at the glutamate receptors. We can see alcohol stimulating the release of endogenous opioids, contributing to some of its euphoric effects. We can also see an enhanced GABA transmission and a transmission that is reflected at the GABA-A subtype receptors. With alcohol, we can see tolerance and cross-tolerance develop in many patients to general anesthetics and barbiturates. And so patients that abuse alcohol at home often exhibit cross-tolerance when they go for surgery, for general anesthesia, or if they're given a barbiturate for any reason. It is the most commonly used and abused drug in the US, and it is technically a depressant. In terms of its pharmacokinetics, this drug is efficiently absorbed into the bloodstream from the stomach, small intestine, and colon, and we get relatively rapid distribution throughout the body. Of course, there is metabolism by the liver. In terms of its effects, we can separate them into the acute versus chronic effects. At low plasma concentrations, we can see a euphoria. We can see a reduction in inhibitory control, that concept of disinhibition release. There's some local vasodilation. There is a loss of coordination, and then there's slurred speech as that blood alcohol concentration climbs. At higher plasma concentrations, the patient can be sedated severely. There can be some nausea associated with that, dramatic mental confusion, respiratory depression, and of course, in the most extreme instances, coma. Patients that abuse alcohol over their chronic or long-term effects will complain of tingling or a loss of sensation in their hands and feet. Sometimes they will develop irregular heartbeats. Of course, liver disease and sexual dysfunction are notoriously known for chronic alcohol abusers. At some point, they do start to lose memory. They become confused, and some patients will hallucinate. GI upset and ulcers are also quite common in this patient population, as well as a loss of muscle tone or muscle weakness. In terms of the terminology for alcohol abuse, we can kind of subdivide it into risky use, binge drinking, and alcohol use disorder. So risky use is consumption of an amount of alcohol that puts individuals at risk for a health consequence. So it could be hazardous use, it could be at-risk use, heavy alcohol use, all those kind of fall under that umbrella. Binge drinking is quite common with the younger population, drinking as much as they possibly can within 2 hours so that the blood alcohol concentration reaches over that 0.08 grams per deciliter, which is kind of that standard that's federally registered. With men, that equates to about 5 drinks, with women, about 4. Patients that have the alcohol use disorder, this is a demonstrated problematic pattern of alcohol use that is more clinically significant and can cause distress. This is based on DSM-5 criteria. Dr. Sheth in psychiatry will talk much more about this criteria, and then how to demonstrate whether or not a patient meets this criteria. In terms of management, we can give a benzodiazepine, specifically chlorodiazepoxide. This will prevent some of the physical symptoms that are associated with alcohol withdrawal. We can use naltrexone, which is the opioid antagonist, and this is often first-line therapy. This drug blocks the effects of the endogenous opioids as well. However, one caveat is that you absolutely cannot give this drug to a patient on opioid therapy. So if they're taking opioids for a clinical outcome, pain management specifically, we can't actually give this drug because it will blunt the effects of those opioids in terms of their pain management. Other first-line therapies include acamprosate. This drug will basically allow for the modulation of glutamatergic transmission and GABA transmission, and it basically reduces alcohol craving, and it's relatively well tolerated. Other management tools include disulfiram. This drug inhibits the enzyme ALDH. Basically, it leads to the accumulation of acetaldehyde. The effects of this drug include skin flushing, tachycardia, hyperventilation, and nausea. And the reason we like to give this drug is that it actually induces a conditioned avoidance response. And so the accumulation of these aldehyde compounds is really quite unpleasant, and it makes the patient not want to drink again. Let's shift gears and examine benzodiazepines and barbiturates. Benzodiazepines all include the drugs alprazolam and clonazepam. They all end in either PAM or LAM. From a mechanistic standpoint, they enhance the function of GABA. They increase the affinity of the GABA neurotransmitter at the site of the receptor. But of course, in order for this drug to work, the endogenous neurotransmitter, GABA, must be present. The side effects include sedation, nausea, vomiting, and there are some active metabolites that contribute to these side effects. In order to negate the effects of an acute benzodiazepine overdose, we can give the antidote flumazenil, and these drugs, of course, have a respiratory sealing effect, which is in contrast to barbiturates. And so phenobarbital, thiopental, secbarbitol, these are all drugs that work similarly to the benzodiazepine, but there are some nuanced differences. They do enhance the function of GABA, just like their benzo cousins. They, however, in terms of the kinetic profile of how these drugs work at the site of the receptor, they increase the time that the channel is open. They are agonists as well. They open the GABA channels. In the absence of GABA, however, and that's really the unique component to these drugs, is that they do not rely on the endogenous neurotransmitter to operate. And so this leads to basically the fact that these drugs are not quite as safe as the benzo class. In terms of their biotransformation or their metabolism, there's numerous enzymes that are involved in the conversion of these drugs to their active components. Side effects include sedation, hypnosis, death by way of respiratory depression, and induction of enzymes, of course. These drugs do not have a sealing effect, and there is no antidote. They cannot be reversed, which is why they're so. So one thing to keep in mind is that the respiratory sealing effect does not occur with barbiturates. Here you see a very nice respiratory sealing effect demonstrated with oral administration of benzodiazepines. And the reason we see this is because, remember, benzos, even increasing doses of benzo, are relatively safe because in order for this drug to have any type of effect, the endogenous neurotransmitter, GABA, must be present. Barbiturates, in contrast, work independent of GABA, so it doesn't matter which dose of barbiturates you give. It doesn't matter how much GABA is or is not available. These drugs work independent of it, and at higher doses, these drugs do produce really potent respiratory depression that can lead to death. So that begs the question, why are these sedatives so addictive? Remember, during disinhibition release, dopamine neurons can fire, and this will release dopamine specifically in the nucleus accumbens, and that results in a mild euphoria type feeling. There is abuse potential with these benzos and barbs, although it is relatively low. They are Schedule 4 officially. We can see the risk of abuse and addiction in patients that already have or an underlying substance abuse disorder.